and today I am going to present the topic of corneal dystrophies. Specific learning outcomes. By the end of this presentation, participants will be able to describe various corneal dystrophies and differentiate between different corneal dystrophies and list the abnormalities and staining of stromal dystrophies and make a treatment plan for different dystrophies. Corneal dystrophies are basically progressive. They are usually bilateral, variable corneal opacifying disorders. They are associated with decreased vision and discomfort, and there is almost always an underlying genetic abnormality. They are classified into epithelial, BOWMAN layer, stromal, decimal membrane, and endothelial dystrophies. Epithelial dystrophies are Corneal dystrophy and MEESMANN epithelial dystrophy. Corneal dystrophy is also known as epithelial basement membrane dystrophy. The appearance is a map, dot, fingerprint, and it is often misdiagnosed due to its variable appearance. It is usually sporadic, but it can be autosomal familial, autosomal dominant. Histology shows thickening of the basement membrane, and there is deposition of fibrillary protein between the basement membrane and the BOWMAN layer. The basal epithelial cell desmosomes are also deficient. Onset is usually in the second decade of life, and 10% develop recurrent corneal erosions in the third decade. Most are asymptomatic throughout their life, and there is bilateral recurrent corneal erosions. If there is bilateral recurrent corneal erosions without any history of trauma, we should always look for any basement membrane dystrophy. Signs are dot-like and microcystic epithelial lesions. There can be subepithelial map-like pattern, word fingerprint-like lines, bleb-like subepithelial pebbled glass pattern, and the treatment is lubrication for recurrent corneal erosion. This figure shows a fingerprint-like pattern of the Corneal dystrophy, and this shows a subepithelial map-like pattern. Next epithelial dystrophy is MEESMANN epithelial dystrophy. It is a rare, non-progressive abnormality of the corneal epithelial metabolism. There are genes encoding the corneal epithelial keratins. It is usually, there is mutations in the genes encoding corneal epithelial keratins. It is usually autosomal dominant. And the histology shows irregular thickening of the epithelial basement membrane along with intraepithelial cysts. This is the histological picture showing a thickening of the basement membrane and intraepithelial cysts. Patients are usually asymptomatic or they can present with recurrent corneal erosions and mild blurring. Signs are there are tiny intraepithelial cysts which are of uniform size. They are maximum centrally and they extend towards the limbus. The cornea is slightly thinned and sensations are reduced. This picture shows tiny epithelial cysts which are of uniform size. Treatment is lubrication for corneal erosions. Besides these, other epithelial and subepithelial dystrophies are leech corneal epithelial dystrophy, subepithelial mucinous corneal dystrophy, and gelatinous drop-like corneal dystrophy. BOWMAN layer and anterior stromal dystrophies. There are two dystrophies: Reese-Buckler's corneal dystrophy and Thiel-Behnke corneal dystrophy. Reese-Buckler's corneal dystrophy. It is also known as an anterior variant of granular corneal dystrophy or corneal basement membrane dystrophy. The inheritance is usually autosomal dominant, and the histology shows there is replacement of the BOWMAN layer by connective tissue bands. In this picture, we can see the basement layer is replaced by the connective tissue bands. Symptoms are severe recurrent corneal erosions in childhood and slight visual impairment. Signs are gray-white geographic subepithelial opacities, which are most dense centrally, and they increase in density with age, leading to formation of a reticular pattern. This picture shows subepithelial gray-white opacities, which are most dense centrally. The corneal sensations are reduced and electron microscopy is required to distinguish it from Thiel-Behnke dystrophy. The treatment is lubrication for recurrent corneal erosions and excimer keratectomy in some patients is required. Thiel-Behnke corneal dystrophy, it is characterized by honeycomb appearance, and it is also known as corneal basement dystrophy type 2. It is less severe than Rees-Buckler's. The inheritance pattern is autosomal dominant. Histology shows curly fibers in the BOWMAN layer on electron microscopy. Symptoms are recurrent corneal erosions, and signs shows network of tiny rings, honeycomb-like morphology, and it predominantly involves the central cornea. Treatment is lubrication for erosions. This is the characteristic pattern showing the honeycomb appearance. Stromal dystrophies. Stromal dystrophies are lattice corneal dystrophy type 1, lattice corneal dystrophy Jeltsin type, granular corneal dystrophy type 1, granular corneal dystrophy type 2, macular corneal dystrophy, Schindler or crystalline corneal dystrophy, and Francois central corneal dystrophy. To memorize in the stromal dystrophies and their abnormality in these stromal dystrophy and the stain which are used to distinguish them, there is a mnemonic. Can somebody tell what is that mnemonic to और इससे बनता क्या है क्लास में gets third man
granular highline or mesenteric
in LA County.
Lattice
और C से
convex.
This is the mnemonic. Lattice corneal dystrophy type 1. This is the classic form. More than 25 heterozygous mutations in TGF-B1 gene are identified. It is inherited in autosomal dominant pattern. Histology shows amyloid which are deposited and which stain with Congo red. There is green birefringence with polarizing filter. This is the histology showing amyloid which are stained with Congo red. Symptoms: recurrent erosions which are usually present at the end of the first decade of life. Typical stromal signs may not be present in some cases and blurring. Signs: there are refractile anterior stromal dots. There are a relatively fine filamentous lattice. They spread gradually, but they pierce the periphery. In advanced cases, there is generalized stromal haze and corneal sensation are reduced. This picture shows fine network of lattice in the central cornea. This picture shows a fine dot-like appearance. Treatment is penetrating deep lamellar keratoplasty. Lattice corneal dystrophy Jeltsin type. It is also known as Meritoja syndrome. The systemic conditions are present rather than it is a systemic condition rather than true corneal dystrophy. It is inherited in autosomal dominant pattern. Histology shows amyloid deposits in the corneal stroma. Ocular symptoms are ocular irritation and late visual impairment. Ocular signs are sparse stromal lattice lines which spread centrally from periphery. The corneal sensations are impaired. Systemic features include progressive cranial or peripheral neuropathies and mask-like phases. Homozygous disease is rare but more severe. Treatment is keratoplasty. Okay, what is this picture and what dystrophy is shown in this picture?
Sorry, breadcrumb-like.
Breadcrumb-like opacities. और किसमें होती है? कौन सी dystrophy में? There are multiple breadcrumb-like opacities with clear cornea, and these opacities have distinct margins. And this is the characteristic of granular dystrophy. It is inherited in autosomal dominant pattern. Homozygous disease is more severe. Histology shows amorphous hyaline deposits which stain bright red with Messin trichome. Symptoms are glare, photophobia, and blurring. This is the histological picture, staining with Messin trichome. Signs are discrete, white, central, anterior stromal deposits. They resemble sugar granules, breadcrumbs, or glass splinters. They are separated by clear stroma. The spread is deeper and outward, but it spares the limbus. Corneal sensations are impaired. This is again a picture showing granular dystrophy, breadcrumb-like appearance with clear cornea. Treatment is penetrating or deep lamellar keratoplasty and excimer laser keratectomy. What is this dystrophy?
Describe.
Describe.
Description.
This shows a splinter-like opacity.
What is this? What is this? क्या है कि? This is a photograph.
Photograph of the.
This is a photograph
of cornea.
cornea. Okay. Next.
This is a photograph of cornea which shows broken glass-like appearance, opacity in the center of the cornea surrounded by clear cornea, and also pigmentation in the periphery. This is most probably latest corneal dystrophy.
एवेलिनो डिस्ट्रोफी, इसमें लैटिस और ग्रैनुलर डिस्ट्रोफी कंबाइंड फीचर्स होते हैं. लैटिस के फीचर्स भी और जो ग्रैनुलर डिस्ट्रोफी जिसमें क्रम्ब लाइक अपीयरेंस होती है और साथ ये लैटिस की फाइन लाइंस होती हैं, इसको एवेलिनो डिस्ट्रोफी या फिर कंबाइंड लैटिस ग्रैनुलर डिस्ट्रोफी कहते हैं. This is also known as type 2 granular corneal dystrophy, Avellino dystrophy, combined granular lattice dystrophy. The inheritance pattern is autosomal dominant. Histology shows amyloid and hyaline because it is combined amyloid in lattice and hyaline in granular. Signs show fine superficial opacities. They spread to form stellate or annular lesions. This shows the stellate and annular lesions. It may be associated with deep linear opacities. Treatment is usually not required. Trauma accelerates the progression of this dystrophy, and refractive surgery is contraindicated if this dystrophy is present. Describe this picture.
A picture of cornea which shows multiple granular opacities throughout the cornea. Surround with the clear cornea in between the opacities. And
अच्छा, इसमें जो है ना मेन यही है जिसमें हमने पिछली पिक्चर में देखा था कि वहाँ पे बिल्कुल क्लियर कॉर्निया था बिटवीन दी ओपेसिटीज. इसमें यह कि देयर इज अ हेज बिटवीन दी ओपेसिटीज, ठीक है, और जो ओपेसिटीज हैं उनके मार्जिन्स भी दे आर नॉट वेल डिफाइंड. और ये होता है मैक्यूलर कॉर्नियल डिस्ट्रोफी. It is autosomal recessive. Gene encoding is CGST6. It is common in Iceland. Histology shows aggregations of glycosaminoglycans intracellularly and extracellularly. They stain with Alcian blue and colloidal iron. This is the histological picture. Signs are dense, which are poorly delineated grayish-white spots. They are present centrally in the anterior stroma and peripherally in the posterior stroma. There is no clear delineation between the opacities. Progression leads to anterior stromal haze, which involves the central cornea. There is eventual involvement of full thickness stroma. It extends to limbus, and there is no clear zone between the opacity and the limbus. Thinning is an early feature, and there is thickening lately due to edema, and edema occurs due to endothelial dysfunction. The sensations are reduced. Treatment is penetrating keratoplasty. This is showing the late stage of macular corneal dystrophy, showing corneal haze with diffuse dystrophy. Schindler corneal dystrophy. It is a disorder of corneal lipid metabolism. There is always association of systemic dyslipidemia. It is inherited in autosomal dominant pattern. Histology shows phospholipid and cholesterol deposits. Symptoms are visual impairment and glare. There is central haze, which is the early feature. Full thickness involvement occurs over time. Subepithelial crystalline opacities are present in 50% of the cases. There is a prominent corneal arcus. Treatment is excimer keratectomy and corneal transplant. This picture shows the Schindler dystrophy, early lesion in figure A and late appearance showing diffuse haze in figure B. Can somebody describe what is in this figure? What dystrophy is and what are the findings?
This picture shows a photograph of cornea, and it shows a hazy cornea, diffuse hazy cornea with somewhat more pronounced opacities.
Polygonal opacities, polygonal or round opacities with clear cornea.
This is most probably Fuchs dystrophy.
We have Francois central cloudy dystrophy. It is clinically indistinguishable from degeneration, which is crocodile shading degeneration. It is inherited in autosomal dominant pattern. Usually there are no symptoms and it is diagnosed incidentally. The signs are cloudy, grayish, polygonal or round posterior stromal opacities. They are more prominent centrally and treatment is not required. Endothelial dystrophies. Endothelial dystrophies are Fuchs endothelial corneal dystrophy, posterior polymorphous corneal dystrophy, and congenital hereditary endothelial dystrophy. Fuchs endothelial dystrophy. It is bilateral accelerated. There are bilateral accelerated endothelial cell loss. They are more common in women, and there is slight increased prevalence of open-angle glaucoma in patients with Fuchs endothelial dystrophy. It is usually sporadic, but occasionally it can be autosomal dominant. Mutations occur in COL8A2 genes, which is the early onset variant, and the late onset variant are TCF4 mutations in TCF4 gene. Symptoms: gradually worsening and blurring in morning due to the corneal edema. Onset is middle age or later. Signs: corneal guttata are seen. Corneal guttata are irregular warts or excrescences on decimate membrane which are secreted by abnormal endothelial cells. This picture shows corneal guttata on specular microscopy, which shows tiny dots on the endothelial surface. Specular reflection, tiny dark spots which are due to disruption of the regular endothelial mosaic pattern of the endothelium. There is a beaten metal appearance. Central stromal edema and blurred vision is in the morning due to endothelial decompensation. In advanced cases, epithelial edema with microcyst and bullae are present. These bullae can rupture, resulting in marked acute pain due to exposure of the corneal nerves. Subepithelial scarring and peripheral vascularization occurs in long-standing cases. This picture shows bullae in the epithelial bullae, and rupture of these bullae will cause severe pain. Treatment is topical 5% NaCl drops or ointment, as they are usually associated with open angle glaucoma. If they are associated, then we should reduce the IOP. Hair dryer can be used, which will cause corneal dehydration. Bandage contact lens, cycloplegia, antibiotic, and lubrication for ruptured bullae. Posterior lamellar and penetrating keratoplasty in advanced cases, and conjunctival flap amniotic membrane transplant is done if the visual prognosis is not good. A new treatment in this dystrophy is topical Rho kinase inhibitor with prior transcorneal endothelial cryotherapy. It stimulates the endothelial cell proliferation and improves the function of endothelium. Posterior polymorphous corneal dystrophy. There are three forms of posterior polymorphous corneal dystrophy. There are associated iris abnormalities, glaucoma, and Alport syndrome. There is basically metaplasia of the endothelial cells. It is usually inherited in autosomal dominant pattern. The genes encoding for posterior polymorphous corneal dystrophy type 1 is VSX1, COL8A2 for type 2, and ZEB1 for type 3. Usually there are no symptoms and it is an incidental diagnosis. Signs are vesicular band-like diffuse endothelial lesions. Treatment is not required. Third is congenital hereditary endothelial dystrophy. It is rare. There is focal or diffuse thickening of the Descemet's membrane. Endothelial degeneration occurs, and occasionally it is associated with deafness. When it is associated with deafness, the syndrome is known as Harboyan syndrome. It is inherited in autosomal dominant pattern, and symptoms are photophobia and watering. Signs are corneal clouding or thickening in neonates. There is the visual impairment is variable. Nystagmus is more common in type 2. Treatment is lamellar or penetrating keratoplasty. This presentation was made from Kansky 9th edition and IVP. Thank you.
Very detailed, especially the SLO was nicely written. So well done. You see, most of these corneal dystrophies present with recurrent corneal erosions, and the patient comes with photophobia, lacrimation, redness, and patient is uncomfortable. So we have to diagnose the corneal dystrophy, and all corneal dystrophies are bilateral, hereditary. They are not associated with vascularization. So these are the clues to differentiate between a dystrophy and an infection or degeneration. So we have to keep three things in mind. Corneal lesion, is it infective? Number one. Or is it a degeneration, or is it a dystrophy? So degenerations are usually unilateral, while dystrophies are bilateral, almost symmetrical. 19-20 का फर्क होता है दोनों आंखों में. So now the main uh, advancement is in the treatment. You see, you have told keratoplasty. So it was keratoplasty was the treatment 10, 15 years back, but now we have deep lamellar. What is DALK? Deep anterior lamellar keratoplasty. And what is endothelial keratoplasty? Good. So we take only the endothelium. Endothelial keratoplasty की क्या types हैं? कोई नाम आपके ज़हन में? DSEC and DMAC. Descent stripping endothelial keratoplasty and descent membrane endothelial keratoplasty. So previously they used to take more of the stroma, and now the emphasis is on taking a thin graft which has minimum stromal tissue, only the descent membrane and endothelium. So it becomes difficult to handle the thin tissue, strip the endothelium and the descent membrane, put it in an injector, just like an intraocular lens, and push it in the anterior chamber. Once the endothelial graft is in the anterior chamber, it usually is scrolled position. Then they tap on the cornea so that it expands and occupies the position. Then the anterior chamber is filled with air so that for some time, half an hour, the endothelial button is opposed with the cornea. There is no air or fluid in between, so it sticks and the endothelium. A few people would recommend sort of removing the endothelium, the previous endothelium, and this is called scoring. With the reverse Kensky hook, you remove the endothelium and the descent membrane of the recipient and then inject this endothelial graft. So many people recommend this additional step so that the graft is in apposition with the cornea. So endothelial graft and deep anterior lamellar keratoplasty. These are the buzzwords now instead of penetrating keratoplasty. So let's say there is a Fuchs endothelial dystrophy or congenital CHED. CHED is found in which age? Young children. Patient presents with hazy cornea. So you doubt that this is a case of ophthalmos. But the corneal diameter is not. So this is a differentiating point between ophthalmos and CHED, congenital hereditary endothelial dystrophy. So you have to graft the endothelium. So when what is the buzzword in DELC? When you do deep anterior lamellar keratoplasty, any bubble? You heard of big bubble? So dissection. So you inject air into the stroma, deep stroma, so that it separates the stroma from the descent membrane. So this is called big bubble technique of Dr. Anwar. Anwar was Pakistani, and he presented this video in American Society of Refractive and Cataract Surgery, and he was practicing in Jeddah for 30-40 years. So this became famous, how to separate So they are type 1 bubble and type 2 bubble. These are the details. But the emphasis is to completely separate the stroma from the descendant so that the graft host interface is clear. If there is remaining stroma, then it will be hazy.
So clear करने के लिए
So what are the advantages of DAL? So and patient's endothelium remains intact. Rejection, there are less chances of rejection, less chances of failure, graft failure. Okay. Quick recovery, mobility is decreased. Usually wound healing is better. The eyeball integrity remains to some extent preserved. If there is a trauma, maybe the superficial graft will detach, but the remaining descendant membrane and endothelium will remain intact. So there are less chances of eyeball rupture after trauma. See, and there are less chances of astigmatism also, because when you do a full thickness penetrating keratoplasty, then the astigmatism is there. So in DELC it is reduced. So these are some of the advantages of.
बिल्कुल इसी तरह जिस तरह कैटरेक्ट सर्जरी में हाइड्रो डिसेक्शन करते हैं, यू डिसेक्ट द कॉर्टेक्स, सेपरेट द कॉर्टेक्स फ्रॉम द कैप्सूल, तो ये है नीमो डिसेक्शन। एयर यूज करते हैं और इसके जो डिफरेंट लेयर हैं उनको आप सेपरेट करते हैं। सो ये अच्छा, इस तरह के जो रेयर केसेस हैं ना, तो एग्जाम में समटाइम्स आपको पेशेंट नहीं मिलते हैं, तो वो पिक्चर की फॉर्म में आपको कवर करते हैं हम, एंड दैट इज आपकी जो टॉक्स है उसमें या शॉर्ट केस के तौर पे वहाँ तस्वीर होगी। ज़्यादातर इंटरमीडिएट मॉड्यूल के लेवल पे आपको वो सारा इंटरैक्टिव सेक्शन ही होते हैं और उसके ऊपर पिक्चर रखी होती है। तो आपने पिक्चर को, सबसे पहला क्वेश्चन होगा डिस्क्राइब दिस पिक्चर, ठीक है। उसको आपने जो भी है, अगर वो फोटोग्राफ है तो फोटोग्राफ, एंजियोग्राम है तो वो, अल्ट्रासोनोग्राम है तो वो, MRI है तो वो पहले नाम आपने लिखना कि ये है क्या, ठीक है। फिर अगर पॉसिबल है आपके लिए तो ये आँख कौन सी है, साइज कौन सी है, लेफ्ट है या राइट है, तो ठीक है। अदरवाइज फोटोग्राफ हो गया, ठीक है, वो आपने डिस्क्रिप्शन देखना। सो नॉर्मल फाइंडिंग तो वहाँ पे होंगी, ठीक है। उसके साथ जो एबनॉर्मल फाइंडिंग है, जो प्रोमिनेंट है, वो आपने बतानी है। तो उसके बाद अगला क्वेश्चन जो होगा वो ये होगा डिस्क्रिप्शन के बाद, व्हाट इज दिस डिफरेंशियल डायग्नोसिस। फिर अगर है तो कौन सा है, और इनहेरिटेंस पैटर्न जिस तरह कॉर्नियल डिस्ट्रोफीज है, इसमें अगला क्वेश्चन होगा कि व्हाट इज द इनहेरिटेंस पैटर्न। उसके बाद फिर ट्रीटमेंट की बात आएगी। फिर अगर कोई इन्वेस्टिगेशन है तो वो, या जिस तरह आपने स्टेनिंग की बात की है तो इस तरह ये 4 या 5 क्वेश्चन होंगे, जिनमें हर एक का 1-1 या 2-2, डिस्क्रिप्शन के ज्यादा नंबर होंगे, 1-1, 2-2 होंगे, और इस तरह मिला के तो वो आपका पूरा क्वेश्चन जो है वो। सो 10 मार्क्स आपको एक स्टेशन के ऊपर लेने होंगे, 10 में से आउट ऑफ 10 यू हैव टू गेट दैट। तो ये चीजें इस तरह से कवर होंगी, लाइक यस्टरडे जिस तरह एंजियोर्ड स्ट्रीक, ठीक है। एंजियोर्ड स्ट्रीक में भी आपको पेशेंट नहीं है तो पिक्चर आपको प्रेजेंट करनी है, फीचर्स बताएंगे, जो बता देगा कि एंजियोर्ड स्ट्रीक है, अगला क्वेश्चन वही होगा कि जी एसोसिएशंस की क्या है, ठीक है। एसोसिएशंस के बाद फिर आप उसकी कॉम्प्लिकेशंस, फिर उसका पैथोलॉजिकल लीजन होती कहाँ पे है, किस लेवल पे होती है, और फिर अगर कोई मैनेजमेंट है, ठीक है। और इस तरह जिस तरह से कॉम्प्लिकेशन आ रही कि भी SRMBM है, फोबिया इन्वॉल्वमेंट है, तो इस तरह की चीजें इस तरह से कवर होगी। तो ये आपको इंटरमीडिएट मॉड्यूल के लेवल पे, वहाँ पे ज्यादा ट्रेंड यही होता है, पिक्चर्स होती है, क्योंकि पेशेंट नहीं होते तो पिक्चर्स के ऊपर ये सारा आपसे एग्जामिनेशन। तो 4 या 5 क्वेश्चन होते हैं हर पिक्चर के साथ।